Thank you. Yeah, I'm good. I'm mic'd. I had to use my hands. If I had that, it would not work right. I would probably somehow physically break in the middle of my talk, having to only use one hand. So I got here right kind of halfway through your first speaker, and it was great to hear someone. I've been preaching about the neuroscience for well over a decade now about addiction, and as was stated earlier, it really is saying something to have people who are non-clinicians understanding the role that the neuroscience plays in talking about dopamine and talking about craving and these things. So I'm going to dig into it a little bit and from a different angle, and hopefully reinforce these basic ideas that as the brain changes through time and is impacted by other actions, what we identify ultimately is it's less of a decision to be in these situations than we want to give it. It becomes more of a reflex in many ways. And so I want to start by talking a little bit about trauma. We'll hit on the neuroscience. I'm going to dig in on craving and what that means from the neuroscience perspective. And then I really want to push into stigma and how we as a community can actually move through that, and how stigma and addiction seems to me to be very different than stigma from HIV that we had to deal with. People want to create the parallels, but I've identified through working in hundreds of communities around this country, it's different. It's subtly different, but it's different, and I think that's important. But before I get started on that, I want to find out who's in the room, who I'm talking to, because that's why many times I won't use slides, because it allows me to know what speaker said earlier, and then if it's stuck on a slide, you got to say it, but now I can just talk about what we want to talk about. And if I make a mistake, you have no idea, because it's not on a slide. So when we talk about this, who here delivers direct clinical care to people with addiction? Great. Who here prescribes medications for the treatment of addiction? All right, got a 1, 2, 3. All right, that's not the best ratio I would like to see, right? These are the things that we'll talk about and what medications mean, because it's not just opioids. We talk a lot about opioid use disorder, but as we know, we don't really have an opioid problem. We have an opioid mortality problem. But what we ultimately have is an addiction problem, and so we need to make sure that we identify these systems and build them so that they can align with all of these things. How many people here know someone and have had to deal with the negative consequences of addiction? Right. This is what makes addiction stigma a little different. And in fact, because of that, I'm going to move that to kind of the front of this talk. And so stigma basically is you identify someone as other, and you have a generally negative thought process about that person who is other. You don't necessarily withhold things from them, but you just give them begrudgingly. And I would say in a hospital, if somebody, one that came up a lot when I was teaching residents, is our patients who come into the emergency department with back pain or knee pain, and they have morbid obesity. And there's the stigma that's there about, well, if you just lost weight, your knees and your back wouldn't hurt. And I hear this behind closed doors, but they grin and they say something generally terribly unempathetically to the patient about how, well, maybe if you lost a little weight, this would be better, and we're not going to give you these, meds for this. And that's stigma. They still offer medications, they still offer treatment, they still offer orthopedics, they still offer suggestions for this. But what we do in addiction is we give someone that label and we see them, and I say that as a practicing emergency medicine doctor, and I get to work at a bunch of hospitals because I'm a locums doc now because I do full-time work building systems, and so I bounce from hospital to hospital and work shifts, and so I get to very quietly watch other people work many times. And what I identify in this is once someone has the label of an addict, that person not only receives emotionally less from the person trying to help them, but they also receive a complete lack of evidence-based care. So that takes stigma and moves it into this new category of discrimination, because the identification of a label and an overt withholding of evidence-based treatment is not just stigma, it's discrimination. And so we've created now a system that is fully discriminating against a group of people that we have the capacity to decrease their mortality rate almost instantly by 50%. And we've made a collective decision in healthcare to not do it. And so this is where it is a little different. And why is that? Why would we think that that would happen? Well, what I've identified is because all of those hands went up, that means we've all been impacted by addiction at some level. We've all had a negative interaction with a friend, with a family member, with ourselves, and we're angry about it. How many people in here know someone in their family who's died of addiction? Right, so my grandfather was a World War II bomber pilot, like the coolest dude you could ever know, and I was the oldest grandson, so I actually got to fly with him in a crop duster a few times. My mom put a stop to that when she saw us flying under power lines inverted, which I thought was the coolest thing ever, and apparently that was not a safe way for a 6-year-old to be inside of an airplane. But opinions vary, but at the end, that was not it. So in my mind was cool. He went into construction, so I got to sit in these big earth movers, and we would do front loaders and backhoe. It was like the coolest thing ever as a kid. But the last memory I have of my grandfather when I was about 11 or 12 was him bright orange sitting on the stairs of a VA hospital from liver failure. And ultimately that was from alcoholism. And I was 11. I didn't know this stuff. He was just grandpa, and he looked funny. And I didn't know what was going on. But that's the last time I ever saw him, and then he died. I didn't really realize how much that kind of impacted me until I started to understand the disease and how I lost this cool person. And then I had cousins. This was back in early 2000s, and I was at this time a doctor in residency. But again, I was an emergency medicine resident, which I have to say is not the training for emergency medicine in inner city Philly where I trained is not really centered around compassion and empathy. It's mostly around gunshot wounds and knife wounds and trauma and how many patients can I see. And my cousin died in the front seat of her car from a heroin overdose next to her brother because he was too scared to take her to the emergency department because he was worried he was going to go to jail. And so she died, and then he eventually went to prison and died of HIV-related issues because of injecting. And I remember back, this is way before I got addiction training, and I remember back how angry I was at him and how angry that actually made me at the people that I saw in the emergency department who looked or made me think like him, or who made me think about my grandfather. Like, what are you doing to yourself? How could you do this? And it was a little bit of a turning point for me in a sense that at that point, I didn't really like my job. I had gotten out of residency and was working at a large healthcare system in the emergency department. By all measures, everything was great, right? I get a good paycheck. I just work, I work my shifts. I go home. But at the same time, I kept seeing patients over and over again, and they would come in, and I would see their name on the list, and I would just get angry, and I would get frustrated, and I would go see them, and I would see them in a way that is, I guess I was kind of a typical doctor at that point, and I was kind of an a-hole. And I would see them, and I would be like, just so you know, I'm not going to give you opioids, so what are you here for? That's how the conversation would start, right? That's not terribly helpful. That's not really caring about this person. That's not any of that. It was anger. And I think that as I saw this happening from all of my colleagues, nursing, doctors, all levels of care inside of a hospital, that was the kind of common interaction that we had with these patients. For me, it pushed me to the point where I actually quit and opened a restaurant, which is super funny. I went and bought a bar. So that's what you do, right? You hate emergency medicine, so you do that. So I did this, but I went and got some training. I went to a conference on addiction because I just was curious about this, and that was my first conference that I'd gone to, and I was like, you're kidding me. This is what this is. And the neuroscience made sense, given I'm a neuromolecular biologist, and I was like, I thought I'd never use that. And then I started through the science to actually gain empathy for the people that I had most maligned over time, and then became board certified in addiction. And then as I started seeing patients with addiction, recognized that a lot of their primary complaints started with pain. And again, I wasn't trained really well in pain, so I went and got trained in pain and board certified in that. And then over time, I realized that my therapist who worked in my clinic that I had started for patients who were in the ER 10 or more times per year or pregnant on a controlled substance. So again, funny, right? I picked the subset of the patients that ran me out of medicine, and now I'm only seeing those patients in the clinic. But when we'd see it, she would tell me over and over, "You need to stop trying to do therapy. You're terrible at it." And she was right. You don't tell a person with generalized anxiety disorder and panic, the way that you get over this is you think of the biggest things that you have fear for and come up with a plan for all of those. So now that I have taken gotten a lot of training in trauma-informed CBT and all of this stuff, I recognize just how funny that must have felt to her to have her listen to me say that to a patient and how bad of advice that was for a patient at that time. But as we looked through this, what I recognized about stigma and how it impacted the care along my pathway is that I had held that anger. I held it and I transferred it directly to the patients that I had seen, and I did it in such a way that it made me a terrible doctor. It made me very bad at what I did because they would come in and they're actually there. And many times they were there because they really wanted help. Despite the behavior that they would have toward me or the clinical situation, they wanted that help, and I did the worst possible thing, and I discriminated against them and basically re-traumatized them. And so as we think about what do we do about stigma, there are parts of it that language can help, but we really have to do an inner deep dive about how much anger that we hold from our history and how much we transfer that onto people with the disease of addiction and how impactful that is in our lack of ability to do good care. So with that, I think that leads me a little bit into the trauma conversation. It was mentioned a little bit earlier today, but as I started doing this for years, I identified that trauma is the great beginner of bad things, right? And so you don't have to have trauma in order to have addiction, but the vast majority people who have significant trauma will end up with either addiction or a mental health disorder just because of the way in which the brain tries to fight back with that trauma. And so when I say trauma, I'm not talking about the trauma I treated patients for in Philadelphia. I'm talking about adverse childhood events. You have physical abuse, you have emotional abuse, sexual abuse, and neglect. And neglect being the worst of all of those as far as what it does to the brain. And then we have the ongoing trauma in the healthcare system, which is basically the discrimination that we levy on people. And then you have larger community trauma. So chronic poverty changes the brain, not unlike emotional abuse, that instability that you get from that. The racial discrimination, if you're a part of one of the races that are discriminated against in the United States, then you actually onboard that trauma. No matter how successful you are, it actually changes the brain in the way that it sees. And it's really interesting research around coding and how you code yourself as one of those discriminated against groups. And recognizing that it doesn't take much for that to happen. And we're generally blind to it in healthcare because healthcare is run by mostly white males, and that's changing. But because it's basically run by that, it's been inherently built to be racist. And that's really frustrating to see, that systemic continued trauma that's delivered to people on a regular basis just based on the way that we've developed systems of care. And whether it's intentional or unintentional doesn't really matter, it just is. And we have mountains and mountains of research that show that the way that we deliver care is discriminatory, not from necessarily just the addiction side, but also the color of your skin side and the culture of your family side. And so we have to be cognizant of that trauma that is ongoing for people who are even in the systems getting care, and how we're delivering it makes a big difference. But early in life is a time in which we can really set up long-term problems. And I always talk about trauma as a gateway drug, because what it does to the brain sets the brain up to have a disproportionate assessment of value to a drug as compared to just regular fun in life or doing good in school or doing good in sports. And the way that it does that is if you're in a house and on 2 or 3 days of the week, Dad comes home, and you always know that it's that day because of the way that the car pulls up in the driveway. It kind of squeals the tires a little bit. It's just revved up when it pulls in, and you get very anxious. You come in, and then there's arguments and yelling and screaming and fighting and sometimes abuse and sometimes worse. And so in that environment, the brain has to figure out how to survive. So it will do a couple of things. There's a part of the brain called the orbitofrontal cortex, right? The orbitofrontal cortex is the part of the brain that assigns value to stuff. So when I get to interact with my kids, that's very valuable to me. So my orbitofrontal cortex will assign that as what I want to do instead of finishing a report, right? These are just how I want to, do this, and we'll figure that out. And then I have this other part of my brain called the lateral habenula that ultimately creates the default pathway for a given stimuli. What that means is that when I hear that car come in, my learned behavior is that I escalate my anxiety, and then I either run or fight or overattach. So think about what we see in personality disorders. If you have a female that's in that situation, she finds that the safety that she gets by, the thing that decreases that physical violence is her over-attaching to that parent when they get home. Hi, I love you, what can I do for you? Would you want dinner? You want all of these things? So they overbuild that attachment and that dependence on that person, and then that becomes their default behavior. We call that dependent personality disorder down the road, because that becomes the default behavior to any type of that violent interaction that may happen to them or that escalation in behavior. If you look at the other side and you take a kind of a typical adolescent male in that situation, the minute they're big enough, they fight back. So their default behavior to somebody coming at them is going to be aggression. And it becomes such that they find value in that aggression because it has saved them from that issue that's occurred in the past. And so if you just follow kind of the time logic on this, we kind of wonder why, well, how does this person become a violent human being? Well, we can kind of walk down that path, and we even know the parts of the brain responsible for creating, that immediate 0 to 1,000 in their temperament to make them interact in such a way that it creates violence as their first act. It is their default behavior, and they actually find value in that because it has given them safety in the past. So think about if you didn't figure out how to compensate for that, and the one thing you found value in was the first time that you smoked weed or the first time that you had a drink, because it finally took away the angst, the pain, the sadness, the anxiety, the frustration, and what it did is it made you not care that was going on. Then you're going to assign a disproportionate amount of value to that substance because it is the thing that helped you in that moment, and then if you do it enough times, it creates the default reaction. We sometimes label this as habituation. And so it's the person who goes for the cigarette or the Xanax the first time that they have any sign of an anxiety attack. That habituation. That is one small slice of what addiction is that habituation. But it's important because if you have early life trauma, it sets the brain up to actually be pulled toward a substance that changes the way the brain perceives the world in such a way that it is the default and most valuable thing that can be done. It's not, I found a friend and had a hug. It's not, I went for a run. It's not, I just did better in school. Because delayed gratification pathways are harder to instill as a default reaction as compared to immediate gratification pathways. How many of you have seen patients with addiction and you're like, they can't think past 2 days, right? They can't think past 4 hours because they're basically just, craving that drug / the dopamine required to maintain their normal lives. And so if we look at how our stigma aligns with the traumatic environment, and as we onboard all of that continued trauma, even for those in treatment many times, treatment can be very traumatic. Think about, just the 12-step modalities. If it's framed in the wrong way, it can be very traumatic in the way that it approaches. In fact, we would say that the core initial pieces of this, at its core, are not trauma-informed because of the way that it talks about requirement of perfection to be successful. You slipped, and so I'm taking away your coin. You decided to use medication, so you're really not clean. And just even using the word clean automatically adds that other level of stigma. And so we have to be careful that we think that a lot of the constructs of treatment that we've developed that have helped a number of people have helped them despite the trauma that it keeps adding. So we can maneuver these things in such a way that we can make them better and make them more applicable and more trauma-informed as we go. So how does this impact, addiction in general? And so the basic neuroscience of addiction you heard a little bit of this morning. And as a neuroscientist, I get really specific about numbers and what those mean, and my numbers may be a little bit different, and that's built out of years of research in the brain and functional MRIs, but I will tell you the concept is no different, right? So if your best day and you're awesome, and your best day ever, the day that you have, you win the lottery, you own an island, and you have 2% body fat, and it happens like instantaneously, right? And you're like, best day ever. That gets you a huge bump in your dopamine. I mean, it really cranks it up. And then the day that is like your really bad day, the day you fake vomit on the phone so you don't have to go into work, right? And then you do, whatever, sit in your pajamas at home in your basement, whatever that is for you. That's the low end. Everything else is kind of in the middle. You know, you have really good days and you're motivated and you're that. And so motivation requires dopamine. You can't have it without dopamine. And so if I say the word motivation, you have to think dopamine. And if I say the word dopamine, you should think motivation, because they are directly connected. And so if you have someone who is 40, you don't really expect them to motivate to get a lot done that day. But if somebody's like 100, then they're going to get a whole lot done. That's great. You're like, game on. You know, we have people that live at both ends of those spectrums. Some are a little higher than others, some are lower, right? So we have the people that sit around that medium high level, and they're always like, it's Monday, this is awesome. And you're like, I want to choke you, because stop, you're irritating. And then you have the opposite, where the people that are just like Eeyores, right? They're just like, I don't know. I mean, I guess it's a raise. You know, it's just that kind of personality, and they live within that. And we all modulate there. And that's fine, we're supposed to be there. What that does is it allows us to assign value to natural things that produce dopamine. You know, that watching my kid get a hit in a baseball game. That, you know, going out and having like 5 seconds with my wife without both children like climbing all over us. Those moments that you really want to have and be able to enjoy. Success at work, like these normal things, those should be the things that drive your dopamine. And it should be that you can crank it up pretty good, and that keeps you motivated to wake up and go do it again. Right? The problem is when the brain gets a signal that wrecks that whole kind of balance. So if you do like methamphetamine and it cranks it up 100 times higher, you know, than what it's supposed to be, then what the brain doesn't like to do that. It knows it's supposed to live here, so what it starts to do is it decreases the production of dopamine. Then, if you continue to use, it actually decreases the size of the neuron that makes dopamine, called atrophy. Just like if you get a cast on your leg, and that cast sits there, you take it off, you got this scrawny, stinky, hairy little leg that sits there. It's like super gross. That's kind of what the neuron is doing over time, is it's just shrinking because it doesn't feel like it needs to make dopamine. Because this other drug is now cranking out the dopamine, so it doesn't need it. And in a subset of the population, you can actually injure that nerve to the point where it dies. It goes through what we call apoptosis, which is programmed cell death, and the body just breaks down the nerve and it disappears. And it's the equivalent of having a stroke in the happy part of your brain. For some people, we don't know the percentage, it's probably in the high 30s to 40% range, that it doesn't come back. Now, there's a subset of the population that if we remove them from drugs and we do all the other stuff right, that at about 18 months to 2 years, that starts to heal. And it can stabilize out, but it doesn't even begin for about 18 months. In fact, things like craving only get worse for the first year to 14 months. It just escalates. So 30 days, people think, man, that's a lot of craving. Well, let's wait till 60 and 90 and 120 and 365. And that's why we find that 1 year mark becomes really telling about where we really are in coping strategies and the capabilities that we've helped people to develop. And when we look at how we approach addiction, we have to think, how do I manipulate the neuroscience to get them to live within that range of dopamine so they can be motivated for and by normal things? It takes time. It takes a lot of time. And so what we run into, unfortunately, is a time in which that dopamine on their best day, after they've been using methamphetamine or heroin or marijuana or alcohol for an extended period of time, their best day might be 40. Their best day might be our worst day. But their average day is going to be way below that. And that way below that could be, I'm not even leaving my house. I'm not getting out of my bed. I'm not getting out of my pajamas. I didn't even put on my pajamas. I just went to bed in what I wore yesterday. And I could barely get out of bed to go pee. And we hear this from patients as we see this. And we may have seen it for those in recovery have had those moments where you just couldn't push. And that is a lack of the capability for the central axis of the brain to produce dopamine. So yelling at someone about motivating isn't going to necessarily change the central axis of their brain and the neuronal structure in order to produce more dopamine. So it just doesn't help, to be that. You just got to pull yourself up by your bootstraps and motivate. Because what you should be saying is, well, you just need to make actually the central axis of your ventral tegmental area and your nucleus accumbens start to produce a higher level of dopamine so that we can actually have the reward system work like it's supposed to. Which sounds less cool. then suck it up. I grew up in Texas, so my father was a Marine. So I got the, why don't you take 2 of these and suck it up, bro? I got some of that. That was interesting. He never delivered those to me, so but that whole possibility in addiction just doesn't work. The bootstrapping methodology creates mortality. And so we have to be understanding of that. So craving in this sense becomes the driver of behavior many times, that craving for the drug. And so I think it's important for us to understand a little bit about what craving is. So craving is kind of this pull toward something despite consequences, like this craving for spending time. So that feeling that you have, that kind of in high school with that first connection you have with the person who you're like totally into, right? It's that, well, it's 4 o'clock in the morning. I need to call them right now. Like I have to do that. And it's you do really weird, stupid things, for that love at that age. As you get older, we find we do less stupid things, but it's also less fun sometimes. But at the same time, that drive that doesn't make any sense, but you follow it, is significantly higher for that. And so there are studies that actually look at craving, and they look at craving for people that are amazingly dehydrated and people who are in starvation, and then those who have been off of their drug of choice. And those studies looked at alcohol and opioids specifically. So they took a group of people, and they withheld fluids for 3 days. So no water orally, nothing in the IV for 3 days. Most of them met for moderate to severe dehydration, meaning when they stood up, their heart rate went up, their blood pressure went down, and they were wobbly, and they were really wanting something to drink at that point. They put them in a functional MRI. At that point, they asked them to talk about water. They played water sounds in the background. They were like sprinkling water on their feet in the MRI. They had them taste water and spit it back out, and they functionally MRI'd their brain, and what they found was that the area of the brain responsible for craving, that cue-associated craving, had the intensity of signal of about the size of a baseball, a relative size of a baseball. So pretty good. And then for food, they had no food for 5 days. They gave them only IV fluids, just enough to keep them from having them be dehydrated, but not caloric intake. And they did that, and then they put them in a functional MRI, and then they had them talk about their favorite food. They would actually bring their favorite food in so they could smell it. They're like wafting it into the MRI. And have them taste it and spit it out, and then they would scan their brains. And then when they did that, what they found was that they had the relative size of craving of about a basketball, right? So pretty significant. And we know what people will do in starvation and dehydrated states, right? They'll steal, they'll hurt other people to take things, and we kind of justify that. If you're running out of food, we're like, if you got to steal to feed your family, that's cool. If you're really hungry and you got to do it, we can internally kind of logic that through. And people will do really crazy things that if you're not in that situation, you can't really imagine. Like, think about walking through the desert for 3 days. I know that if I had to walk through the desert for 3 days and I get to the end of it and I had nothing to drink and I have this beautiful big glass of water right in front of me, condensation coming down the side, like a Sprite commercial, it's just that perfect like glass, and I go to grab it and somebody steps in front of me and says, no, that's my water. I'd be like, okay, stab, and then I'd move them over and I'd take the water and I'd drink the water. So with that, what we would get from that is a reaction of, well, that idiot shouldn't have stood in front of the water. That guy was going to die of dehydration. I mean, we'd kind of blame the person who got stabbed for making a really stupid decision. And with that, we would justify that, and we could internally justify that. So what does it look like when we look at addiction and the behaviors associated with addiction? Now remember, we define addiction not based on the presence or absence of a substance, right? If you have cocaine in your system, it doesn't mean you have a cocaine addiction. If you have marijuana in your system or anything, it doesn't mean that you have an addiction, because an addiction is a series and a set of behaviors about how you use and obtain that drug and the detriments that it has on your life. So just because you're positive for something in your urine doesn't mean that you have addiction to that. I've had plenty of people who, in the Saturday morning shift, when I show up and I'm reviewing the people that are getting signed out to me, and they're positive for alcohol, marijuana, cocaine, benzodiazepines, and then I find out it was just they were the best man at a wedding and it went really wrong, and afterwards. So I mean, those things happen where they actually don't do it. I mean, a set of bad decisions doesn't equal addiction. Now, it definitely equals risk, but we have to remember that addiction is I am choosing. I assign value of a drug over that of my family, over that of my bank account, over that of my friends, over that of work. And then I have behaviors to obtain that drug and use that drug that put me in physical harm, that put me in jeopardy of jail. So when we think about, remember that early trauma and that orbitofrontal cortex, that value assignment, that has to have now changed from the things that most people would hold normal, kind of valuable, and flip that as to the substance or behavior. So gambling, things like that also fit in there. And then when we add in that default behavior to a response, anxiety, a little feeling of withdrawal, any of those things, that default behavior is an immediate pull toward that we hold most valuable, and that's the drug. So we looked at this and what it looked like for people who had been off of opioids or off of alcohol after a withdrawal event, 30 days, 60 days, 90 days, 120 days, and then a year and 18 months. So we looked at all of these groups, and what we found was really interesting. Craving over time went up, like we talked about, but didn't level out till about 18 months to 2 years, and didn't start to improve in most people until 2 years. So it really took about 2 years for dopamine to start to stabilize and normalize, and then in those that it would go up, but they found in a subset, it doesn't go up. It just hits a peak that's way below normal. So we looked at craving, and they asked him only a couple of questions. The question was, tell me about the first time that you used and the last time that you used, and then they showed them some cue pictures of the drug that they had used on a regular basis. And instead of the size of a baseball or the size of a basketball, the signal for craving in the lateral prefrontal cortex was about the relative size of a baseball field. And it actually decreased the signaling from the old part of the brain, the very center part of the brain where reward sits, easy for me to say, and the disconnect between the frontal lobe. So 50% decrease in the frontal lobe signaling. So half of the signal is going to the part of the brain that's responsible for making complex decisions. And most of it is sitting in this pure portion of the brain that is responsible for, I need to fight, flight, and survive. And it sits really inside of that part of the brain. And so when we're asking them to do very complex things like get their kid out of foster care and have to do all of these paperwork and show up and do this and do that, and go to treatment and still have a job, I mean, we're asking really the impossible of a lot of these patients. And so when we start to look at trauma setting the brain up as ultimately a prodrug, moving into how we stigmatize the whole system of care to make it really impossible for people to get really empathetic, trauma-informed care, and understanding that behavior that we see with craving, it becomes really obvious after you've seen a number of these patients why we're not doing a good job, why we're failing. And I would say that despite the best efforts of some individuals, the system has failed. And the system has failed because the system's default reaction and the system's value proposition are not aligned with the patient. And we have to figure out how we get from a system that sees a patient as an addict and says they'll come and get help when they're ready, to one that says, you have the same mortality rate as a person who comes in with a heart attack that I did nothing for. As we look at how we intervene and how we start to make the differences in what we're doing with this patient population, we have to look at what does the data show, what does the science show, and how do we just build that into a system. We already do this for every other part of healthcare. We already have, if you have a heart transplant, an entire system around you to make sure that you can get this heart transplant, go back to rural America, but still have really informed care through your primary care doctor, through a contact person at the transplant clinic. They've done that. We figured this out for dialysis. We figured this out for diabetes. We figured this out for that. And the interesting piece is for opioid use disorder, it is the easiest addiction to treat by far, without question. We can be 70% successful in treating opioid use disorder. And that's not even in a perfect system. That's in an adequate system. So as we start to look at why are we not doing this, what gets us that outcome? Well, for opioids, and I think it was talked a little bit about this morning, medication-assisted treatment stabilizes the dopamine axis. And when you stabilize the dopamine axis, we increase dopamine, and what does that give that person? Motivation, meaning they're going to show up to their appointments, meaning they're going to show up to court, meaning they're going to follow through on the things that they need to fill out a job application, to do the things that they need to at family. These are the things that we do. And the interesting piece is that for buprenorphine and methadone in an opioid use disorder, in 1 year's time, it decreases the mortality rate by 50%. Let me say that again. If I start somebody on medication and do nothing else at that point, like low threshold initiation, I haven't started CBT, I haven't done any of this other stuff yet, I just give them a medication, I decrease their chance of dying in the next 1 year by 50 to 60%. If I have a patient who comes to the emergency department and they have this rhythm called VTAC, and I shock them, what percentage of those people will I save? Yeah, the best studies showed 20%, the best studies, and that's if they have it in front of you right then and you just need to move the rhythm. But even on the regular side, it's between 5 and 11% is what it is, right? But we've decided that that's enough to actually put automatic external defibrillators on like Burger King restroom walls, right? So that we can have a perfect stranger shock another perfect stranger in public. We do this. They're there. You walk around airports. I've used one of them at an airport on a person, and it was great that it was there. But at the same time, we've made a huge effort within the system to put this out there and do that. But we're not making that same effort on a systemic, sustained way to be able to put in the key and fundamental pieces of treatment for addiction that decrease mortality way past what a defibrillator does, way past what an aspirin in a heart attack does, way past what a clot-busting drug does in a stroke. These are all standards of care, meaning if you don't do it, it's malpractice. I would say that in healthcare right now, identifying a person with an opioid use disorder and not offering them medication-assisted treatment is malpractice. I would also say it's unethical. And we don't have to do that by maligning other treatments. It doesn't mean that other treatments are wrong. It just means they need to integrate with this early approach. Because the scope of practice of a person who prescribes a medication is a pretty narrow set of people. I don't know of any treatment programs that are like, I don't think that's the right beta blocker for you. I don't think you should be on a statin. They don't comment on any other medication. Yet it can be very, very traumatic in the way in which they comment on medications for the treatment of addiction. So let's talk about alcohol use disorder. 4 very good medications for alcohol use disorder. One of those being injectable naltrexone, lasts for 30 days, decreases total drinking days by about 50 to 60%, decreases amount taken in by each episode that you have. How many alcohol recovery programs offer this as a modality for this? How many people use Camprosate? How many people say, well, if you're on these medications, you're not really clean? It's unacceptable. How many of these people sit around and smoke a pack a day? I just want to call a spade a spade. Let's be honest about this. Let's have the conversation. We should not expect perfection from a disease that is imperfectible. People should be able to live their lives and have access to treatments that save their lives. Because I will tell you, when people say, well, naloxone, they're just going to go back and use again, the answer would be, well, they're alive. And if they do, then we'll be there again to offer them treatment. Because I cannot fix a dead person. I cannot give a chance to somebody's kid who didn't make it. I cannot give a chance to somebody's parent who didn't make it. We have the capability, once we identify these people, to get them into treatment and to do a very good job with treatment. But we have to build the system that does it, and we have to take away our own internal stigma, our own anger, our own pieces that withhold this, and hold each other accountable for delivering the evidence-based system that we know is helpful for these patients. Not let our emotions get in the way of science. We are doing that way too much in medicine, especially around addiction right now, and it's problematic. But we also have to recognize that everybody has their path to recovery. And it's not the same for everybody. So people need to be informed of the choice, informed of the risk, and have access in an unstigmatized way to whatever choice they make. If you have addiction and you want treatment, maybe you don't want that treatment. That's fine. I want to explain, however, the risk and the benefits and why we want to use that treatment. But if you don't want to, I'm going to work really hard to find you the treatment that you want and what fits you. And I think we have to build that agile system because everything, if you have a hammer, everything's a nail. So we need to have a hammer and a screwdriver and paper clips and whatever else we can put together, because maintaining in treatment, whatever form that is, improves your outcome. But the difference between outcomes for opioid use disorder is the 12-step self-help modalities as the primary modality of treatment is 8 to 12% effective for opioid use disorder, and methadone is 70% effective. Buprenorphine is between 55 and 65% effective. And naltrexone, we don't have enough studies yet to know exactly how effective, but it's between 22 and 65%, or what the studies have done. So when we look at how we're going to build the systems, we need to not only have access to medication, but we should stop putting boundaries on which medication we're going to use based on how I feel about that medication. When I talk about methadone, and it's already been said in the room, the word methadone, but generally the first time that you say the word methadone in a crowd, even of addiction treatment professionals, there's usually a collective deep breath or a sigh. It's like, methadone. I mean, why do we have such a weird emotional attachment to a medication? I don't, no matter what else I say, I don't ever hear that. And the thing about methadone is not necessarily the drug itself, but the way in which it's delivered. Think about people in this very chaotic, severe form of opioid use disorder. They don't have a stable, living situation, do they? Generally speaking, it's pretty chaotic. And so an opioid treatment program has the capability to create daily interaction that allows for them to actually have the first stability they've had in years, if forever, especially those who had early chaotic, traumatic lives. And so when we start to look at how we build systems, we have to have that as one of the availabilities. We have to have buprenorphine because some people can't or don't want to have to show up every day to get it, and they should have the right to do that. We should have the access to naltrexone, even for those that feel like they would like to try that or use that to see if it's helpful. But the interesting piece is we talked about the core fundamental final common pathway for all addiction is a low dopamine state, right? If you are not able to produce natural dopamine, you're not what? Motivated. If you read the insert for naltrexone, it says, works well in motivated patients. This is problematic. However, there are a subset of the population that can still produce natural dopamine even after they've been using a substance for an extended period of time. And those are people who may do very well with that medication. So we have to start assessing true motivation and not just being so prescriptive about, well, this is what I do, or this is what I think. Because you know what? I don't care. It's what the data science and math says and how we apply it to the individual. And we have to remove kind of our emotional contextual realities and figure out how we build a system so that people can get the care that they want. For opioid use disorder, 12-step modalities is very helpful, but it's about dosing and timing. Meaning it's not the first only modality that you use, but once my patients begin to get very stable, I have to figure out how to reintegrate them back into connectedness. They have to figure out how to be with other people. They have to figure out how to tell their story without it triggering this need to use a drug. We have to work on that, and one of the best ways to do that is to talk with other people in recovery. I can't have that conversation with them. I'm not in recovery. I don't have that lived experience. I can tell them about the risks and benefits and the data and the science and the math and what I've seen for thousands of patients I've treated, but I still don't have that lived experience. And so that lived experience is really, really important when people are in early recovery to stabilize. So what's frustrating is if I have them really stable, moving in the right direction, and I hand them off to that, and they're like, well, you shouldn't be on that treatment. It's kind of not your scope of practice, to be honest. I mean, there's a part of this that you shouldn't really be pushing on that. We should all be on the same information. We should have the same information, and the data is the data is the data. Recognizing that there are people who've gotten better only using 12-step. But when you do rigorous evaluations, meaning if I put random people into random interventions, how do they do? The data around the 12-step modality as a primary mode of treatment for opioids shows very clearly that it doesn't work. It's worse than placebo. So it may actually be causing harm as the primary modality for opioid use disorder. Now for alcohol use disorder, it's better. It's still not great. It's about 26% for alcohol use disorder. But then when you add medications, you can move that up to about 50%, which is still really good. So we have to start really thinking about how we integrate all of these large-scale systems of care and not let them be so delivered from a viewpoint of a religion or the viewpoint of a theory, but just overlaying the data science and math into the system that the patient feels most comfortable being in. Because maybe they're not comfortable in my office. That's fine. I don't have to be the primary person who's doing the treatment. I will manage one small portion of it, and I will connect you with the other pieces of treatment that are helpful. We have to be able to build that treatment plan. So, when do you want me done? I know where time's going. Perfect. So, I have found that it's actually more fun to answer your questions than it is for me just to stand up here and hyperbolically preach. So I would like to take a few questions, and my goal with the questions is to actually answer them all the way into the weeds. Anybody ever watch Tosh.0? Right, where he takes a joke and he takes that joke all the way to the point where he's finally just lost everybody, right? So part of my goal is to say, just to finally answer the question so deep into the weeds that there's nobody here who has anything left to worry about that. And it's also a little bit of stump the chump. So for those of you who feel like things that I've said maybe didn't resonate, you feel like it's not really accurate, you want to push back, that's great, bring it on. I mean, my whole life is about knowing this stuff and learning this stuff and teaching this stuff. And so if I don't know something, I need to know it, and I don't mind being embarrassed in front of 400 people, right? So I want you to bring it up. And I want to be able to answer it so that we can all end on the same page. So who would like to ask the first question? And I'll repeat it so I know you won't be able to hear it. Yeah.
Can you give us the dopamine levels for the different drugs, including sugar and what's normal?
Yeah, so the question was, can I give you the dopamine levels for, for what's normal and kind of sugar and stuff like that? Sure. So I will give you the dopamine levels specifically measured in the nucleus accumbens, which is a specific part of the brain, not the whole reward system, because you can do both of those. My numbers come from the nucleus accumbens, which is the primary final common pathway for addiction. Your normal when you wake up is around 50 nanograms per deciliter, and that's kind of what you need to get out of bed and get that first cup of coffee. Your best day ever is about 100 nanograms per deciliter. Your favorite food centers around about 94 nanograms per deciliter. Sex is about 92, bummer, but it is what it is. And your worst day ever is about 40 nanograms per deciliter. And that's where that goes. So methamphetamine pushes that to about 1,100 nanograms per deciliter. Heroin is in the 900s, alcohol's in the 800s, marijuana in the high 600s. So specifically the THC component in marijuana is at about the high 600s. So as we start to look at anything that pushes it above 100 has an addictive property. Sugar is a really interesting one because we do find in a subset of the population, it triggers dopamine release no differently than heroin. So there's a subset of the population that gets the same dopamine rush from sugar as somebody who injected heroin. This is really scary because we find that eating disorders, specifically the overeating disordered individuals, this may ultimately just be a glucose addiction. Or even, we're now finding that rapidly absorbable high fat content may do the same thing in another subset. And it's in the satiety loop. It's a little bit of a different part of the brain, but it still finishes in the nucleus accumbens in that population. And if you look at the behaviors that are exhibited with food, they match the behaviors that we use to define addiction. You know, they choose food over friends. They'll eat food despite having a gallbladder attack, and they know that it's going to happen. They'll still eat it. Despite having diabetes out of control and the risk of DKA, they'll still do those. So that decisional pathway goes. But then if you dig back into their history, what you find a lot of times is trauma. And what they found is that food was one of the ways in which they could find a reward. It was one of the ways in which they could actually find relief from the world around them. And so what happens is you end up with that same issue that we talked about earlier, which is you get this default reaction to a situation, that habituation that we see from the lateral habenula. The default reaction to the situation is to go straight to the thing you find most rewarding, which is assigned by the orbitofrontal cortex. And so you have this stress, you have this sadness, you have whatever that trigger is, and your default non-cognitive thing, it's not a pros cons list, right? It's a reaction. It's just like I hit your knee and you had, your patellar reflex. If I did that, then their default is going to go to food. And we find that that's their default for those situations. It's actually even, sadly, parodied in movies. I mean, how many times do we see the sad eating a tub of ice cream in front of the TV as just a way to talk about coping? for that, but for a subset of the population, it's a pathology, and it turns into such that it causes long-term and even medium-term harm. So that's a great question. And again, while those may sound different than the previous, I'm talking about a very specific location in the brain, but as you can tell, the concept's the same no matter what you talk about. Yeah. Yeah, so the question is, what are we seeing right now around the country with marijuana and the medicinal marijuanas and the different THC contents versus CBD contents versus, all the other pieces, especially since the, quote, medicinal marijuana, which I would say the correct term for that is voter-approved marijuana, just to be accurate, because it hasn't gone through the normal processes of what it is, and generally speaking, when it's prescribed, it's not prescribed. It's allowed via a certificate to be used. It's not prescribed in the same way with, generally speaking, a quantity, a number of times per day, and a thing like this, and people experiment. So just to be clear. So I'm not going to give you my opinion. I'm just going to tell you what the science shows. The science is actually pretty deep in a lot of the aspects of marijuana, despite what we hear a lot. There's over 20,000 publications on the use of marijuana for medical conditions since the mid-90s. So it's not that we only have 5 publications. It is hard to do a lot of this work, obviously, because of the scheduling of marijuana and the way that it's been difficult. So some of this work is done out of the country, and a lot of it is European Union data, where they've used large cohort data, which is not always directly applicable, but at the same time gives us a guide. So first, the only research that showed that THC was helpful for pain looked at HIV peripheral neuropathy and MS peripheral neuropathy, and it was at 6%. And if you went to 9%, it actually worsened pain in controls. In that set of the group. If you went to 3%, it didn't work. So the data that we have for that uses pain, that it helps for pain, or for the peripheral neuropathies, those specific peripheral neuropathies, not general peripheral neuropathy. And it was only a 6-month study, and it was 6% THC, not 80% THC, or higher when they're vaping, or things like this. So, and they didn't know to measure CBD. And so the studies only looked at THC content because we were still kind of finding CBD and identifying what it did. So it didn't really talk about, we can't really say causation, we can only say correlation for that because they didn't look at the whole enchilada. Now, as you produce higher THC strains of marijuana, it necessitates from the internal plant mechanics to decrease the CBD production internally. So generally speaking, as you increase THC, you decrease CBD, which changes the ratio. What we have identified is that CBD, cannabidiol, acted as a buffer for the side effects of THC. So generally speaking, if in balance, which seems to happen at about 6% THC in a natural plant, then you don't get the side effects of overt anxiety, psychosis, and the significant dopamine effects. It seems to help limit some of those things that occur. What we're going to find, and these are Rand Corporation predictive analytics, and I would tend to agree with these, is marijuana is not going to be a mortality driver like opioids is, but it will be the most significant morbidity driver in all of healthcare over the next decade to 2 decades. And the morbidity is going to be psychiatric morbidity. We're already seeing, and it has already been the #1 cause of admission for adolescents for the last decade for addiction treatment. We're seeing a rapid rise in the admissions for psychotic events in those that are smoking on a regular basis, whether it's dabbing or whether it's vaping or whether it's just smoking regular weed, than we've ever seen before, and it's continuing to go up. And we're finding that as they age into the early college age, we're finding that there seems to be some permanence in these conditions, and it's not fully reversible like we had hoped that it would be. And so that's kind of where we're at. As far as pain, there are no studies that show that marijuana increases function. So if somebody wants to smoke marijuana or use the marijuana byproducts for palliative care, hospice care, I don't care. Who cares, right? You're in pain relief mode at this point. And if somebody wants to smoke weed every now and then, I also could care less. But I will tell you, in the patients that I see, the vast majority of my patients don't smoke every other Saturday. They smoke in the morning, they smoke in the afternoon, they smoke at night, they dab throughout the day. They have an addiction to marijuana. And so we need to just start identifying and separating out who has a marijuana use disorder from those that just use marijuana, just like we do with alcohol. And I will tell you, the data from the 1940s and 50s for alcohol for pain relief is better than the marijuana data. It relieves pain. I'm not going to prescribe it, right? So we just need to think about what we're doing. And I do think that there are studies that are in the process that will help us to better understand what components of marijuana, because remember, marijuana is 90 psychoactive substances, and we don't really know what all of them do. The most well-studied is THC, and we're finding it's probably not helpful for pain long term, and the side effects of it significantly increase the chances of psychiatric comorbidities as you go, including anywhere between a 12 to 25 times increase in the risk of developing permanent schizophrenia. And it does that by changing what we call arborization patterns. In the brain, we have all of these interconnections that come in, and those help, right? You get one idea, you can think about other things, you can do something and kind of think about other things sometimes, and you can draw from old experiences. That's because all these neurons in the hippocampus and other parts of the brain interconnect. They touch each other and they communicate. But you don't want them to over-communicate, so we have this arborization, which is basically tree trimming. It goes in and it clips the ones that are redundant, maybe we don't need those connections, and that happens throughout our entire life, but mainly it happens between the ages of about 5 and 20. And that's when we're going to capture our ability to take ideas and move it together. So what it does is it decreases the trimming phase. So you get the growth phase without the trimming phase, and those that, when you do that, that means you can have a couple of extra voices going on, which that may sound cool until we actually diagnose that as schizophrenia, because you can't tell the difference between which one of those is reality versus which one of those is just the inner voice and psychosis. So we have a structural phenomenon that we can identify with marijuana that's really scary. I mean, I have a 7 and a 9-year-old. It freaks me out because I see this neuroscience. I still read the basic science on a regular basis, and we're about to have a flood of information that just supports this, because it's now in the secondary basic science phase where we're finding it in cell cultures and animals, and it's been very consistent in the outcomes. And generally speaking, that pattern falls right into human science. And then the human fMRI studies have really solidified this arborization theory for what it causes. So we're going to see an increase, and we need to be ready for this, an increase in behavioral dysmorphology in people who use marijuana on a pretty regular basis. And we're going to find that people who have technical jobs, if they smoke it, they do worse at those jobs, because there's a lot of stuff that it does to what we call actualized random memory, which is you get in a car, put your seatbelt on, turn your key on. You don't have to think about that, right? It's just kind of automatic. That gets significantly decreased with the use of marijuana 3 days after use. So if you smoke on a Saturday, on Monday, you still have a significant decline in that. So if you work heavy machinery, you work in healthcare, you're a pilot, this is problematic. And so these are things that we have to just have this conversation about. Cat's out of the bag at this point, where I don't think we're going to go backwards on this. We should have moved earlier on decriminalization and all of that stuff, but I think we just need to recognize that we've allowed smoking to occur again, and it's just a different set of outcomes and downstream effects that we're going to have to deal with. So when we monetize it and tax it, we better tax it enough to build these systems.